Welcome to the ASGE video tip series. I'm Dr. Chris Thompson from Brigham and Women's Hospital, and I'm here with one of our second-year GI fellows, Dr. Matt Skinner. He's going to tell us about a patient with an adjustable gastric band and one of the more common complications.
Our patient is a 37-year-old female who was referred to us from the bariatric surgery clinic. She underwent laparoscopic adjustable gastric band placement 5 years ago, but for the past 6 months has been experiencing epigastric pain and substernal burning consistent with GERD. We subsequently proceeded to endoscopy.
During the endoscopy, erosive esophagitis is notable at the lower esophageal sphincter. Just past the LES, we enter the pouch, which is separated from the stomach by the gastric banding system. Particular attention is paid to the length of the pouch to ensure that it is neither too small nor too large. The mucosa is evaluated to ensure that the band has not eroded through the gastric wall. We then pass through the band from the pouch into the rest of the stomach. The site of the gastric band is then viewed in the retroflex view to again ensure no erosion. Here we demonstrate a technique where we pass back and forth across the band site, feeling closely to note any catching or clicks which could signal a band erosion that may not be readily visible. We then proceed to complete the endoscopy by visualizing the pylorus and then the duodenum.
The laparoscopic adjustable gastric band consists of 3 major elements: the actual band, which sits in the gastric cardia, tubing, and a subcutaneous injection port. It is buckled into place over an orogastric balloon with a goal of creating a 50 cc pouch. Hiatal hernias are typically repaired prior to the procedure. The adjustable gastric band is associated with the lowest intraoperative mortality rate of 0.05%. Unfortunately, the adjustable gastric band is associated with a high rate of revisional surgery, and the majority of bands are removed due to a lack of weight loss. Roughly 40% of patients experience major complications, including pouch dilatation, band erosion, band infections, and esophageal dilatation, and a further 22% experience minor complications, including incisional hernias, port tubing disconnections, port infections, and esophagitis is seen in this case. Esophagitis is relatively rare in these patients, and the B trial in 2002 noted that esophagitis occurred in less than 1% of patients. Additionally, a study by Dixon in 1999 noted that in patients that had esophageal reflux and erosive esophagitis prior to band placement, 90% had improvement, where only 4% went on to develop worsening esophagitis. However, in patients that present with reflux symptoms, 44% are found to have erosive esophagitis on upper endoscopy. These low rates of esophagitis are likely due to the fact that surgeons are more careful to address any hiatal defects prior to band placement. Treatment of esophagitis in adjustable gastric band patients involves maximal dose PPI therapy, and it's also recommended that the band be deflated. Patients who do not improve with these conservative measures should consider revision surgery to gastric bypass.
So what else are you looking for when you're evaluating these patients endoscopically?
Well, there's several things that you have to be aware of. Whenever someone has esophagitis, there could be contributory factors. Stenosis of the band can lead to worse reflux and can contribute to esophagitis. A fistula from the pouch to the rest of the stomach can also lead to more acid getting into that area and worsening of symptoms as well. And whenever you're scoping an adjustable gastric band patient, you really have to look for any signs of band erosion. So you might see the band itself eroding, but it's also very important to feel for that. And as you're going through the outlet of the band, if you feel any unusual resistance or friction, you really should be take a very careful look in that area for band erosion. Additionally, when you go through the band and retroflex, it's important to decompress the stomach rather abruptly to see if there's any sign of erosion at that point as well. I guess furthermore, you should also examine the patient's abdomen in the port area, because occasionally band erosion can be associated with a port infection and cellulitis. So those are things I look for.
Thank you.
Thank you.